HIV Epidemic Scientific Working Group seminar. My name is Amanda Castell. For those that don't know me, I am a co-lead for this EHE-SWG and a co-director of the DC Center for AIDS Research. And I'm happy to have my colleague, Abby Charles, also joining us, who also co-leads the SWG. Today, we are going to hear from one of our EHE investigators, funded investigators, Dr. Donaldson Conserve, who's going to give us an update on the development of this community-based PrEP service delivery intervention for Black adults that he and his team are working on. Let me just start by introducing Dr. Conserve and his colleagues. So Dr. Conserve is an associate professor in the Department of Prevention and Community Health at Milken Institute School of Public Health here at GW. His research focuses on implementing and disseminating evidence-based HIV prevention care and treatment interventions for scale-up and population-level impact. He received his master's and his PhD in biobehavioral health from the Pennsylvania State University and completed his doctoral training in the Department of Health Behavior at the Gilling School of Public Health at University of North Carolina at Chapel Hill. He's working with a large team, but I want to just introduce two additional members of his team. Nana is a first-year Master's of Public Health student at GW who's specializing in global health, epi, and disease control. She holds a Doctor of Pharmacy degree from Ghana, where she developed a deep interest in understanding and combating infectious diseases. Nana is passionate about leveraging her pharmaceutical background and public health training to contribute to global health initiatives and improve disease prevention and control. And then finally, I want to introduce Christian Morris. So Christian hails proudly from a bonded community in New Orleans, Louisiana. After moving to rural Alabama following Hurricane Katrina, Christian has been on a mission to build community environments that uplift each of our different perspectives and experiences. Christian is currently pursuing a career in clinical psychology in order to apply science and empathy to empower individuals to live their best lives. Christian brings a bright, fresh perspective to engaging our diverse communities here in the DC metro area, and currently is a research coordinator at Us Helping Us People into Living Incorporated. So with that, I am going to let Dr. Conserve start his presentation, and we should have ample time at the end for a robust discussion and Q&A. Thank you.
Thank you very much, Dr. Castell. I'm going to, just before I start the presentation, I have the pleasure of having one of the multiple principal investigators on the call. We didn't know she was going to be able to make it, but it seems like she is able to make it. So I'll just introduce her quickly, and then I'll go to the presentation. So Dr. Martin is one of the multiple principal investigators for this project, and she's on the call. She's a senior associate at the Population Council with over 20 years of research focusing on the lives of vulnerable and underserved and historically marginalized groups in Africa, Asia, and the US. And her research has focused on the strategies to overcome barriers to HIV and sexual health services. And as I go through the slide, her work in Tanzania is the foundation for the project that I'll be presenting today. And we are very grateful to have her on the call. So as the slides shows, the title of the presentation is called The Development of a Community-Based HIV Pre-Exposure Prophylaxis Service Delivery Intervention for Black Adults in Washington, D.C. And I've had the pleasure of working with a large team, as Dr. Castell mentioned. And as you all are familiar, you know, these kind of projects are not possible without the many support that we need. And as people are referring to, team science. So this is just one of those examples. We have been fortunate to be supported by the DC Center for AIDS Research. And also I lead the Bridge Research Lab, which includes many of the students who have been assisting with this project. So just a brief overview about the history of the funding and the collaboration that led to this project. We started brainstorming the concept for this project back in 2022 when the call for funding was released. We first had to submit the concept note, and initially, and this is, I think, important, I felt, because the initial organization we wanted to start working with when we submitted the concept note did not want to move forward. And thankfully, with the support of the DC-CFAR and the Department of Health, we were able to find a new community-based organization partner with colleagues like us helping us. And that is the only reason we were able to move forward to the next phase to receive this funding that started in 2022. And the foundation, as I mentioned earlier, for this project is based on an intervention that Dr. Martin and her team at Population Council and the Ministry of Health in Tanzania, as well as Japigo, Tanzania, implemented in Tanzania with female sex workers, where they provided community-based HIV screening as well as community-based treatment initiation for female sex workers at a tent or either at a client's peer educator's home or wherever that was most convenient for the client, and compare the outcomes for that intervention with the standard of care, where individuals were required or were referred to the facilities for the treatment for HIV once they received a positive diagnosis. So over the 6-month intervention period, the findings show that those clients who were in the intervention were more likely to initiate ART, but also more likely to adhere on ART, and also reported that they experienced less stigma when it comes to accessing services for HIV. So building on this project, when we started putting the concept notes for the project in DC, we wanted to maybe transfer this intervention for community-based ART in Washington, DC, but the data for Washington, DC did not show that HIV treatment initiation was an issue. At least the rate was not low enough for us to have a strong justification for conducting community-based ART. So upon further review, we learned that PrEP initiation actually was very low, and as well as HIV incidence was very high, especially among Black adults. So during this brainstorming, we then decided that we would want to address PrEP barriers to PrEP uptake by adapting this intervention in order to help increase potentially PrEP uptake among Black adults, where the data showed Black adults in the Washington, D.C. area were experiencing a higher rate of new HIV infections over time. In data from Whitman Walker Health reports that only 21% of the PrEP patients identified as Black back in the time when we started putting the concept note together. And the Department of Health reported that in order to reduce HIV incidence by 56%, there would need to be an increase of 13 or close to 14,000 individuals to take PrEP in order to have the impact that they would need to have. However, we know that for PrEP and some of the services, there are several barriers that prevent individuals from initiating these services. And for PrEP, some of those factors include transportation. So the standard of care for PrEP services in DC and probably most of the US is that you have to be, receive the prescription, and then you have to go to the clinic to receive that prescription to then be able to collect the PrEP regimen and continue to follow along, to be adherent, and maybe going to the pharmacy, or maybe finding, if there's an organization that provides different kind of services that are more convenient. But for the most part, the standard of care requires individuals to come and receive the prescription at a facility, and then so forth and so on. But the transportation, the mistrust are also related to interacting with providers in these facilities. And even before you get, transportation and mistrust, you have a lot of people who may not be aware of PrEP and may associate PrEP with maybe risky behaviors only for certain groups based on the advertisements that have been done so far for PrEP. And at the same time, we know based on the evidence from our own projects and from other projects that have been conducted outside of the US, there's a lot of evidence that shows we can address some of these barriers by having services at the location that is more convenient for the client. So whether that's at a tent in the community or organizing with peer educators to schedule a time that would be convenient in a location that's convenient for the client, whether it's the peer educator's home or the client's home or somewhere else, those factors have been very effective. So the goal we had for this project was to use what is being referred to as reverse innovation. So taking evidence from sub-Saharan Africa and other countries to implement here in the United States. So the first objective was to adapt the community-based ART intervention from Tanzania for community-based PrEP intervention for Black adults in DC, and then assess this adapted intervention for acceptability and feasibility. So we've been fortunate to publish our protocol paper for the community-based PrEP project here in Washington, DC. So if anyone wants more information, you can access it in +1. But this is also showing the qualitative paper. So the first publication I showed for the project in Tanzania was the quantitative paper, and then we did follow-up interviews with the clients who were in the intervention to just learn more about their experiences, and they reported, that the quality of care was very high and up to par, and of course in some cases even better than the standard of care. So to adapt the intervention for community-based PrEP for Black adults in Washington, DC, we've been using the adaptive model, which has 8 phases. And the 8 phases include assessment, decision, adaptation. For assessment, it's really just most people will do formative research, which includes qualitative interviews or engaging with different stakeholders to learn more about the community. So in our case, we, Dr. Waymarton and I, we had very limited experience in working in Washington, DC, and with Black adults. So we were very grateful to have our colleagues at us helping us to help us navigate, the DC scene and helping us to connect with the different stakeholders who are providing services for the Black adults in DC, but also engaging Black adult potential PrEP clients and current PrEP clients that we would interview for the assessment phase. And for the decision phase, we already knew the intervention that we wanted to use and adapt, but we've been discussing as a team, the several iterations of what the intervention would look like based on the initial findings from the formative research. And we are currently in the process of finalizing the adaptation for the intervention. And then we are hoping to complete the other steps, including the production of the intervention, final protocol to share with the topical experts in the area. So going back to maybe some of the people we interviewed for the first phase, but maybe engaging additional individuals to give us feedback so that we can then have a final protocol for the intervention and train all the personnel that would be involved in the pilot of the intervention. So for the engagement for the assessment phase, we started conducting key informant interviews back in January of 2023, and we took most of the year. So we went from January 23 to November of 2023 to conduct our interviews. We started with the community-based organization providers who have provided HIV testing services in the DC area. And then we also interviewed staff from the DC Department of Health who were involved in PrEP services, as well as Prince George County, and then went on to engage potential PrEP users as well as current PrEP users. And for the recruitment, we had a very good success with the staff at CBOs and also some of the potential PrEP users. But when it came to current PrEP users, we had a little bit more challenges, especially being able to recruit heterosexual Black women, I remember, was one of the difficult challenges. And we also have other team members on the call, so they can confirm, when we stop. We've conducted our preliminary data analysis, and now we are preparing to move really into the remaining phases for the adapted model so that we can potentially pilot the intervention starting this summer. So as I mentioned, we engaged different stakeholders, so we're able to do a total of 38 key informant interviews, and the breakdown for the different subgroups. We had 9 participants from CBO leaders, and then we had 3 staff members from the DC Department of Health, as in Prince George County, and then we had healthcare providers who themselves are actually providing PrEP services in the DC area. And then for the current PrEP users, we have 8 participants and then 13 participants for potential PrEP users. So after we collected the data, we came together as a team in October of 2023, just to be all in one room and discuss what we had noticed from the transcripts that we had been reviewing, and started to code and just get feedback from all the members in the room. As you can see here, we were able to have several members from us helping us. This is Nana, this is Dr. Tan, and then another student from GW here, and then Christian was also on the call. And I believe I was the one taking the picture, so that's why I'm not in the picture. But this really allowed us to have a sense of potential opportunities, but also challenges that we will need to be mindful of as we prepare to conduct, the pilot study. And so the summary really from some of the findings indicated that the participants perceived, the potential CV PrEP intervention as having a positive comparative advantage in comparison to the standard of care. And their recommendations included making sure that we have diversity when it comes to the providers, as well as the language of the staff. So being able to speak, not just English, but thinking about individuals who may not, who English may not be their first language, as well as having insurance navigation teams, giving that for someone to start PrEP, it has to be covered by health insurance, and then if not, then we need to have the alternative option that would allow the individual to start, PrEP on the van whenever we start. In addition, some recommendations included, certain location, so making sure that we not just, going all over the city, but having consistency in the location that we provide the services, having additional coordination, and more importantly, thinking about how to not make it an HIV, service intervention only, but to kind of reduce the stigma that is associated with HIV that we would experience. So thinking about making it more of a general community health screening intervention, including screening for other diseases, and then along that line, process, kind of introducing PrEP to a person, and if they are interested. So not just making it about HIV and PrEP, and thinking also about other ways to reduce the costs that may be associated with PrEP services, relying on the fact that we have to again use the health. So now for the decision and adaptation phases. So we have been, having multiple discussions as a team about, the different components that we would want the intervention to have. These are not finalized at all. So any feedback, at the end of the presentation is welcome. But one of the, first component, is going to be that it will be a community-based organization-led PrEP service, which will be piloted by our team members at us helping us, and us helping us, as well as the staff at other CBOs already have very strong connection with their community for different services already. So this would allow different, starting with us helping us, but the other organization that we would hopefully engage to be involved in piloting or scaling up this model would be able to kind of add these services to their project. And maybe some of the organizations are already experimenting, with similar models. But based on the interviews that we conducted, we did not necessarily find an organization that was doing this as part of their standard of care, or long enough maybe to consider it something that is, that would be duplicating efforts at this point. The second component, as also was recommended, is making sure that we have, staff members and community health workers who are aligned with the communities that we are planning to work with. So as you can see here, Us Helping Us already has diverse staff, especially when we think about Black adults who are the focus of this intervention. We are going to be able to have this as a key part of the intervention, and kind of leverage the strength of Us Helping Us and potentially other organizations who don't have maybe as this strength. Then we could maybe share this component and maybe provide suggestions on how to meet this part of the intervention. And then the third component is related to providing this integrated screening model, where we would not just provide, we would not just announce this as an HIV community-based service, but more of a general health screening, so that individuals who come, they would be offered a variety of screening services, whether it's for other STIs or hypertension, diabetes. I think even some other services that Us Helping Us already provide would be incorporated, the kind of bundling this main intervention with other interventions that already exist at Us Helping Us. Dr. Innocent, can you mute yourself? Okay, thank you. And then the last component, so after we do the general screening and someone tests, negative for HIV, then we would offer them the possibility of being screened to see if they are at high risk for HIV. And then if they are at high risk for HIV, then we would we would refer them to the van that you can see here in the back of this tent, where they would then be able to have additional information about PrEP and the process for initiating PrEP on the van. And the initial goal we had when we designed the project was that, thinking about what we did in Tanzania, is that someone would be able to, come get screened for HIV and also determine their HIV risk. And then from there, they could be eligible to receive a 30-day supply of PrEP right on the spot, right? But after going back and forth and learning about the context here in DC, the policies, the regulations, we have kind of settled on the fact that we may not be able to provide that 30-day supply initially when the person first come to the van, but we could do the 7-day supply and then collect enough information from that person to make sure that the insurance would support the 30-day supply, and then also the blood work that needs to be done, and then invite them to come back at the same location or somewhere else that's convenient for them, where we could do the follow-up delivery of the 30-day supply in the community somewhere that's convenient for them. So that's where we are currently, and we are very open to any additional guidance and even people on this call as we move forward. So the next steps are to, again, following this adapted model, to produce the final, kind of like a close to a final prototype of the intervention or protocol, and then sharing that with topical experts, and then eventually integrating the feedback that we receive from the experts, and then to start the training of the community health workers and other team members that will be on the van and the tents to provide the screening and linkage to PrEP. And we are hoping to pilot, the community-based PrEP intervention among 60 Black adults starting hopefully in June, and if not, then definitely by July we want to be in the community we have started doing the run through the surveys that we plan to use for the baseline data collection, and hoping to just finalize as many of the next steps so that we can actually hit the ground running. This is just a slide to acknowledge the different the funding from the DC-CFAR, the support we have received from the Department of Health, both from DC and Prince George County, the great the participants who have made their time and the team at us helping us, and then the many students, as you can see, who have been involved from the beginning. Actually, you know, just one student, Bukola, was part of the team before we became so big, so large, and we started thinking about another project. But then when this opportunity came, we were able to kind of pivot and apply for this based on the preliminary work that Bukola started doing, who's an undergraduate student, and presented on this project for her own internship. So thank you very much. Please.
Thank you, Dr. Conserve. That was great. You all have really accomplished a large amount of work already in a short time, and I'm excited to see this go forward. We're going to open it up to questions, and for those of you that you can either raise your hand or you can put your question in the chat. I will just start off with kind of two thoughts and a question for you.
Thank you. Let me grab my pen, make sure.
Well, so
and also I'll just say that we have other team members who can also chime in, right? I imagine. Okay.
Yeah, please. So just a thought in, oh gosh, probably 2014, 2015, we had funding before EHE to do some work like this with community-based organizations, and actually did a project with Community Education Group where we looked at hotspots for HIV transmission, and a very similar approach. We did kind of on the ground HIV testing. They had an insight into the communities that we were trying to reach, and they had a van available, and we could, if somebody tested positive, they would drive them to their clinic of choice to get them linked to care. So as I'm hearing you talk about this intervention, it really resonates with me. I'm wondering if you all have thought about how you're going to locate those hotspots. And I would just suggest that that might be an opportunity to collaborate with DC Health and PG to look at their data to see, you know, where there is the most need, where there are the most new diagnoses or incident infections, and maybe those are or maybe you've already thought about this. So.
Oh, thank you. Thank you. I think this might be a good question for the Us Helping Us team. I see go ahead.
Yeah, absolutely. So is my audio working okay, everyone?
Yes.
Okay, great. Great. Yeah, so Us Helping Us currently uses surveillance data for DC and PG County to do some of its current programs around HIV testing on the mobile unit, we call it. So the PrEP component is innovative for us, but we do sort of work in tandem with surveillance data in DC and PG County to identify hotspots. And then I also want to say that we use, or for phase one, just sort of the qualitative interviews, asking community members where they think would be beneficial to sort of go, which may or may not be a reflection of the actual statistics, but we sort of have both of those sides sort of informing where we'll actually locate and do the outreach, the mobile outreach.
Great. Waymar, did you want to say? We can't hear you. We can't hear you, Waymar.
Oh, sorry, I was on double mute. Yes, thanks for bringing up the point about the HIV testing that's been done on in the community through tents and mobile vans. And I feel like this is where this project is unique, right? Because yes, there has been a lot of community-based testing, and that has worked really well. So we're really building on that and bringing PrEP. And so I think that's where this project is extending that work.
there any questions from the audience? I could ask another one, but I want to give others. Okay, well, while people are coming up with their questions, I guess I had another more comment than anything. I wonder if you spoke with, I'm not sure which other community-based organizations were part of your formative work. My understanding is that 110 Health is also doing work like this. And I know that you
Yes.
mentioned one of the barriers was the prescribing for 30 days versus 7 days, I think.
Yes.
And I'm just wondering if you had talked to them about what their experience was, because I thought they were doing a 30-day supply, but I could be wrong. I don't know.
Thank you. So we interviewed 110 Health, the director, and we also confirm, and us helping us may be able to also follow up on this, but what they were doing was actually in collaboration with us helping us. So they were doing the screening because they had the model for the screening, and then they collaborated with us help. So us helping us would bring the van for the prep 7-day supply, and that where it ended. So unless that has changed since then, I don't think the 30-day supply is being provided from upon that initial encounter by any organizations. But I would be very excited to learn, to connect with anyone who may be doing the 30-day supply upon initial encounter at the community, if possible.
Yeah, I don't know. I didn't know. I didn't recall what their, how many pills they were able to dispense. Is I would think that if you're able to dispense in the community, I don't know why 7 versus 30 days makes a difference. I don't know if that's
Yeah,
a
so
legal issue, medical legal.
yeah, I think there's legal, but also the fact that I don't know if it's possible, I guess, for all the blood work and the insurance requirement to be completed on the van. But maybe Christian, are you able to add any more information? Because I know we went back and forth a lot on this.
We Yeah, I think there are both medical and legal restrictions on how much you're able to give upfront. So I can speak a little bit to the clinical side of it, just under the guidance of the nurse practitioner who is the clinical director at us helping us. They're comfortable dispensing that 7-day supply immediately, but they essentially standard of care is to wait for a confirmatory HIV negative status via blood draw. So that has to go run through the lab, basically. So I think that is the medical holdup without just or why we don't dispense the whole 30-day supply up front, just to get some basic blood work back. I think not only confirming HIV negative status, but also proper kidney and liver functioning. So you don't want to give someone too much medication up front when it's actually obviously not compatible with their body. So that speaks to the medical side of that.
And I'm going to maybe ask a question to anyone on the call. If there's any information on how a 30-day supply could be provided, for PrEP, or is being provided anywhere in the United States. We would be grateful to learn more how it's being done, if what special approvals may be needed, even if to do it in a study instead of thinking about just the service model, because we do have approval for a study, so we could potentially try to have the 30-day supply, because that I think would push, would allow our evidence to be more, I guess, different than starting with the 7-day and then coming back for additional supply in this after 7 days.
I don't know. Please feel free to speak up if you have experience with that. My experience is more clinically based in doing it. I mean, would give somebody a 30-day supply if they were interested, and then we would follow up their labs and call them if they needed to stop the medication, you know, if there was some contraindication or something like that, or if their confirmatory test came back positive. But in a community setting, I don't know.
So I guess maybe you can share a little bit about the clinical facility-based experience, at least for me. So if I'm correct, you can provide the 30-day supply upon the initial visit with the client, and then you wait for the results of you know, the kidney function and all these other factors. So and after that, if there is an issue, you call and tell them to stop, as opposed to preventing them from getting the 30-day supply. And for the insurance process, that's also completed very quickly during that initial encounter, or do you then reach out to that person after, you know, like how long does it take to confirm the insurance is going to cover? Is it like a quick phone call? I know sometimes you know, some physicians do, or dental clinics do.
Yeah, honestly, you know, my prep providing is actually at the DC Health and Wellness Clinic. So
Okay.
that's the experience I have there. And, you know, it just depends on if people are insured or not. Obviously, if they're come in with insurance, then it's relatively easy to get them covered. If not, then we have a navigator who assists them with getting insurance, you know, either copay insurance through one of the commercial, one of the pharmaceutical programs, to help, you know, defray the cost of PrEP. So,
Okay. Okay.
Right there.
Amanda, is that same day initiation?
Mm-hmm.
Oh, okay.
Mm-hmm.
Okay. Yeah, I think that's helpful to know, because I was kind of pushing the team for us to just go with the 30-day supply. And I guess, you know, the model you share, you know, call them if there's an issue, tell them to stop. I don't know. I don't know why that wouldn't work in the community setting, since it's part of the DC base, you know, policy to do so, I imagine, right? It's not limited to DC Health and Wellness.
No, I think in any clinical setting you can do that.
Okay. Okay. Well, that should be good food for thoughts for us.
Yeah, I mean,
That's-
I'll say one more thing and then we should probably let other people contribute to this conversation. But, you know, initially when we were starting to do it, we were doing 7 days and then we were having the person come back. And that's also just to look at side effects, you know, to make sure that there are no issues around adherence. And some providers do choose to do that. They still want people to come back after that first week, just because they want to make sure that the person is doing okay. And then obviously you can review the labs with them at that point. So, but many of us have shifted to just doing the, you know, starting with that 30-day supply. Are there any other questions from others on the Zoom? Then I'll ask another question. Have you you kind of alluded to it, but could you share with us a little bit more about what kind of the long-term follow-up plan is? You know, will people be initiated, and then are you planning on following them in the community long-term, or is the plan to eventually transition them to a facility-based clinic? And I don't know what the experience was in Tanzania, if you're going to build off of that as well.
Thank you. Currently, we planning the pilot for a 60-day follow-up. So the goal would be to have the 30-day supply giving, and then reach out to the participant for our follow-up survey. But then they can also choose to engage with us helping us clinical team to decide whether they want to come to the actual, you know, location of us helping us, or continue to meet with the team at a convenient location, or just collect it, you know, in the pharmacy of the choosing. So that's what we have discussed so far. But Christian and Waymar, you know, feel free to correct me if I'm wrong.
Yeah, so I think in addition to that, what's nice about working with Us Helping Us is that they do have multiple strategies that they're using right now for prep follow-up. Christian, you can add to this, but I understand you also have the delivery. You can provide prep delivery to them at their place of their wish. And so I guess it'll be really up to Us Helping Us to see if they want to continue doing the van service. So I think we'll just have to see what this pilot shows us. In Tanzania, with the community-based HIV services, the Ministry of Health was involved, so they are doing some variation of the community-based strategy.
Yeah. I would just add, I think the time point is 45 days following initiation, not 60. And then, yeah, so we're working out sort of the kinks around how do we offboard someone from study participation and just sort of enroll them into prep coordination services from Us Helping Us. So, there will be a point where follow-up just looks like regular prep care, however is most convenient for that particular client. But we will collect some data and information at the 45-day mark just to understand sort of their experience thus far, keeping in mind that a lot of the people who we do bring prep to through this intervention are going to be prep naive. Yeah.
I think that leads into a great maybe conversation about the implementation science aspects of this. So it was really exciting to see, adapt it kind of in use here. I think this is a great example of a really great IS approach to use. And I wonder, just thinking about that, thinking about the feasibility, obviously you all are going to be assessing that, but also kind of long-term sustainability as well. And thinking about not only from the client perspective, but have you thought about, I guess Us Helping Us is thinking about it too from an organizational perspective. And then also, have you thought about it from like an outer context in terms of the health departments kind of adapting this approach? And it may be premature to be thinking about all of that depending on your outcomes, but just wondering if you could kind of talk us through a little bit more of those longer term outcomes and how you intend to measure them.
Thank you. I will say with the overall goal is definitely to support the scale up of this model in DC and other settings where it may not be the standard of care. However, we know that will be different, in different cities and different states, and will require the support of the policymakers and the Department of Health. So we are not, at least I've learned to not think that just because the evidence may be there from the pilot or from the other project, that would be enough. But we are engaging to the best that we can the different stakeholders who would be able to kind of maybe support and advocate for this model. In Tanzania, I'm excited to share that the evidence from this project and other projects have contributed to a change in policy where community-based initiation of ART and PrEP is standard of care. And we are planning to continue working with people in Tanzania because we want to enhance that model of delivery for those services, because just because you have it, it doesn't necessarily translate to something that does not require any additional support. And for the longer term outcomes, we are hoping to measure those with a potential R1, because the evidence from the pilot will be great, but I don't think that would be robust enough for everyone to say, oh wow, let's take your evidence from Tanzania and then from this 45-day pilot study and just scale this up. So our goal is to really leverage this pilot study, apply for an R1 or other funding opportunities that can continue to strengthen the evidence and eventually potentially have the changes in the impact that we would ultimately want this project to have.
Yeah, and it's a good point you mentioned too, because we know that, PrEP initiation is so much easier. It's the maintenance that's more difficult, right? So, with a longer term study, we can look to see what strategies are best for preventing like the early drop off, right? Which is a huge challenge.
Exactly.
Yeah, I had a question. I was interested with this mobile outreach and assessing clientele, whether they're at risk for HIV or not. There's a lot of, there's new and up and coming different methods for PrEP and PrEP delivery. I'm wondering if if you're only advertising standard, taking PrEP every single day, or if you're also advertising different types of PrEP, such as 211, depending on people's risk criteria eligibility, or if that's something that you've considered.
So for this one in particular, we're focused on just the oral PrEP. And yes, we definitely acknowledge that there's a long term, and us helping us just started to do it, the offer the long term, long acting a few months ago. So, I mean, right now this project is approved for the oral PrEP. So, but we could look at the longer term, just look at us helping this initial data on how that is going, and maybe we can incorporate it as part of the next funding.
Yes, I would say we had not considered how to just the 211 or intermittent dosing, because we're building the brochures and like sort of prep promotional material. So that's something we should discuss if we want to include that information. Yeah, as far as 211.
And I also believe that the options that will, that are there would be included in the larger study. So for an R1, we would be able to leverage this pilot data and propose to then use that same model to have, multiple options. And maybe by the time we are fortunate to have an R1, then there will be more flexibility in the different options, and maybe even the policy would support the 30-day supply initiation, and give us a chance to follow along maybe how people perform, or how those outcomes vary for those maybe different options of PrEP and so forth and so on.
Yeah, absolutely. Thank you. I mean, I was just thinking about it when, evaluating people's risk criteria, especially in the community setting rather than a clinical setting, whether it's like, oh, we don't know if maybe we can follow up with this person or if they will actually come back. So what are different alternatives that we can provide to them? Because sometimes, oral PrEP and adherence can be difficult when there's no standard point of care and continuous point of care from there. But thank you. I appreciate it.
Thank you as well.
Any other questions, comments, thoughts? Well, I want to thank you all for your work. I think that this has the potential. First of all, as somebody whose foundation was in international health, I love to see examples of what's worked in, some more resource limited settings, and applying that here in the context of the US and specifically DC, because, I always say necessity is the mother of invention. And oftentimes the creativity comes out of those situations. And I think we take that for granted sometimes here in the US. So I'm really excited to see this work being done here and being translated into the US and the local context. Also, again, just loving to see the implementation science work integrated into this approach of really focusing on that EHE pillar of prevention as well. So we will, be excited to hear about your preliminary results and how this rolls out, and, all of the different outcomes that you all are going to be measuring over the coming months. I do also just want to let the group know that, as I mentioned, this is our last EHE Scientific Working Group event. EHE activities are going to be integrated throughout the rest of the CFAR. And so some of that work will be forthcoming. And then for those of you that are interested specifically or working in the area of implementation science, that work is going to be incorporated into our social behavioral sciences core. And so we will continue to be able to support those of you that want consultations on implementation science as the supplements have been phased out, as people are interested in applying in R01s focused on implementation science. The SBS core will be the home for that work. Those of us that have been on the EHE SWG will still be available for support and resources, as well as our collaborators at Johns Hopkins. So while the SWG is going away, the work will continue to be done. And we hope that you all will continue to engage in that manner with us. So.
Thank you. I will also just say thank you for inviting us to have this opportunity to share, the work that you have been supporting us with from the beginning, and we look forward to sharing results and our, next steps, in future presentation. So.
Wonderful.
Yeah, thank you, everyone.
And thanks everyone for joining this morning.
You all have a great day.
Take
Bye-bye.
care.
Thank you.